Hello and welcome back. This is Dr. Cassandra Quave, and you're listening to Foodie Pharmacology, the science podcast for the food curious. This week on the show, we're going to touch on a topic that is near and dear to my heart, and which I know will resonate with many of our listeners. And this is the topic of food as medicine. And I've got two incredible experts on the line today to talk about their work from the angle of being in a hospital and using food as medicine as part of their clinical care program. Our guests are Dr. Rosette Chakkalakal. She is an associate professor in the Emory School of Medicine, Department of Medicine, as well as the director for the Division of Preventive Medicine in the Department of Family and Preventive Medicine. She is a practicing internist at Emory at Grady, faculty practice at the Grady Memorial Hospital Adult Primary Care Center in Atlanta, Georgia. She's also a core faculty member in the Emory Global Diabetes Research Center. Our other guest is Kathy Taylor. Kathy is the director of medication nutrition therapy at Grady's Health System. She has served as a registered licensed dietitian for the past 29 years. Thank you so much, both of you, for coming on the show. It's really great to speak with you today.
Thanks so much for having us.
Great. So I thought it might be helpful just to orient our listeners to tell us a little bit about what Grady is like. What is the patient population that you all serve?
Absolutely. So, Grady Health System is a huge network. Many folks that live here in Atlanta, Georgia, recognize Grady by being that big hospital that you can see off the highway when you're driving by downtown. I've had the pleasure of being part of the Emory and Grady faculty for quite some time, and Kathy is part of our Grady Health System staff as well. It's one of the largest safety net healthcare providers in the southeastern U.S. The reason I say it's a very large healthcare network is because in addition to that big main hospital, you can see when you're driving down the highway, there are several neighborhood health centers and associated health centers that are across Fulton and DeKalb counties to serve the needs of the residents of our county. A recent survey that we did in the primary care center within Grady Health System, meaning at the adult primary care center at Main Grady, we found that 73% of our patients reported annual income less than $25,000, and 55% report food insecurity, which we're going to talk a little bit more about here. So, it's a population in need, a population with quite a bit of chronic disease, and also a population that has a lot of socioeconomic needs that we try to work with through our programming, definitely including our food as medicine program.
Amazing. Well, and I want to touch on this idea of food as medicine. Maybe, Kathy, can you tell us a bit about what do we mean? What do you mean by that? How is food medicine in this context?
That's a great question. What we consider, especially as nutrition professionals, that is our go-to medication. And it's kind of a different way for our patients to think about managing their disease states. We here at Grady, we have initiated a food as medicine program back in August of 2020. But before that time, we had partnered with a couple of our physicians, Dr. Jada Bussey Jones and Dr. Stacy Schmidt, who did a survey of our patients and found that about 50% of our patients were showing as food insecure. And that's about 140,000 of our patients, which was 4 times higher than anywhere else in Atlanta. And so they partnered with Folsom Wave, Georgia, and Open Hand to provide a food prescription program for those patients. And in the process, they had such good results with that one cohort. They really wanted to expand it. So they came over to my department, medical nutrition therapy, and said, hey, can you join us in this partnership to get our patients, more accustomed to understanding food as medicine? And so we did. We started with 5 cohorts with about 15 patients each. We expanded that the next year to 7 cohorts and really showed the worth of this kind of program of increasing fruits and vegetables, showing patients how to cook those fruits and vegetables, and then also providing them with those prescriptions every week so that they're picking those up at the local MARTA market or the local farmers market. And so leadership took notice of that and said, hey, why don't we, expand this even further and build out a space for this program. And so at about the same time, one of the fast food restaurants here on campus, the contract came up for renewal, and they decided not to renew it and instead build a food as medicine hub for Grady in that space. So instead of fast takeaway burgers and fries. We now have fast takeaway fruits and vegetables for our patients. So that was a big win for this hospital and for this community.
That's amazing. Wow, there's a lot to unpack there. I'm going to start with the income percentages. $25,000. I think it must be really hard to live on, on that kind of level of income, especially supporting a family, considering inflation and the rising grocery prices. What are the types of foods that these patients would typically be purchasing prior to engaging in this program? Are we talking primarily about ultra processed foods? I know that often our food banks, unfortunately, are heavily stocked with a lot of ultra processed foods because of their shelf stability. Um, what's in a typical diet of someone before they begin the program?
Sure. And you're exactly right. Ultra processed foods, easy to get foods from like the local bodega, the corner market, where you rarely see, a fresh fruit or vegetable. And so much so that when we brought patients into the program, they had never been introduced to foods like zucchini or eggplant. And so this was really foreign to them, which was why it was really important to make this a really well rounded program and partnership. We are partnering with the Atlanta Community Food Bank to provide this program of uh, cooking classes, nutrition education classes with the dietitian, as well as the food pickups, and then also having them work with our physicians, like Dr. Chakkalakal, to ensure that they are, not only being reinforced to attend this clinic because we consider it a medical clinic, but also to make sure that they are checking their labs, adjusting medications, those kind of things, which are really an important part of this program.
It's great. Well, Rosette, could you tell us a little bit more about the types of health challenges that food insecure individuals might face? Is diabetes a major issue here? What else are these patients facing?
Yes, it's a great question. And I think a really good way to kind of anchor the conversation about food as medicine initiatives. So we've mentioned that term food insecurity a few different times. And I think it's important for us to understand what we mean by that. So if we look at a definition of food insecurity, it can be defined as a lack of consistent access to enough food for an active, healthy life. And I think Kathy and I see that, that's the definition, but Kathy and I see that clinically all the time with folks that come and visit us and seek out care for their management of their chronic condition. Research has definitely shown us that food insecurity has a strong connection to many chronic diseases, including some of the ones you mentioned, like obesity, hypertension, and diabetes. We see that for those conditions, the rates of food insecurity are significantly higher for patients with those conditions. For me, a lot of my time that I spend as a primary care physician and a researcher, I spend working with individuals who are living with diabetes. And to be honest, I think that's really where I started learning a lot more about how food insecurity can affect disease management. And also having the good fortune of being able to work at Grady and learn from Kathy's team that this is absolutely a part of our clinical management of our community. And so seeing how it affects diabetes is critically important. From what we know in research among adults diagnosed with diabetes, we see that food insecurity contributes to worse self-management, worse glycemic control, which is basically their ability to keep their sugars in the range that we want them to, which is associated with better long-term health outcomes, and also greater emergency healthcare use. So, when Grady was interested in really supporting the programs that Kathy, Dr. Bussey Jones, Dr. Schmidt were starting out, a lot of that has to do with the fact that these are the things that are our bread and butter at Grady. We're working with folks that are dealing with things like diabetes all the time. And if there was a way that we could work on something upstream, like food insecurity, to really help some of these things like emergency healthcare use or getting hemoglobin A1C, which is our measure of diabetes control, getting that better controlled, that's a great win for all of us, for our patients, for our providers, for our communities, for the health system. I found it really helpful for myself when I started really learning more about how this actually impacts disease management to look for a conceptual framework, because I think that's really the way that we as scientists oftentimes understand this. So there was a review published in 2021 that identified 3 key pathways by which food insecurity contributes to worse disease management, not just for diabetes, but for many other cardiometabolic diseases. The first one is when you really think about like a nutritional way. So if someone is food insecure where they can't get enough food for an active, healthy life, they're pretty constrained in terms of their dietary options, and they may not be able to have as high of a diet quality. That kind of gets to the question that you all were discussing earlier. If you're limited in what you can choose by what you can afford, you may not get the healthiest options available to you. And so you're constrained in the dietary options. And maybe the foods that I'm telling you during your clinic visit, hey, you should be eating more fruits and veggies. Maybe those aren't the most affordable. And just the second pathway is the compensatory pathway. So thinking about trade-offs. So for example, if our patients have a hard time affording healthy foods, that probably means they're also having a hard time affording your medications. And at some point, they may need to make some decisions about, do I get that medication that we were talking about, or do I get this other food option? And then that really decreases their capacity for self-management. And then the third pathway is a psychological pathway. So you can imagine if you are living with food insecurity, that could be a source of depressive symptoms, decreases the patient's ability to feel strong self-efficacy, and increases their stress level. And again, those are all things that we can associate with disease management, and recognizing that in and of itself, that also affects worse disease outcomes for folks. So I think one of the things that struck me in learning a lot about the program that was put together at Grady is that it's not just a program where folks have access to healthy foods, which would be great, just that, but it actually thinks about all of these pathways and how the program can really support much more than just the access question, but also, helping with self-management, helping work through those self-efficacy issues, thinking about stress management, and kind of like the network around our patients and how we can help them.
It's great. When I think about food insecurity, it's my understanding there are multiple aspects to it. We have access, so economic access, but there's also physical access. I know in Atlanta, we have a number of areas we would call food deserts where there is no fresh, produce available within a certain area that's accessible. But then we also have knowledge gaps in how does one transform this food. So have you found that all three of those are important drivers of food insecurity and the patients that you work with? And how does this program begin to tackle those issues?
I'll say just a little bit because I think Kathy can probably answer this really well. One quick way I'll mention that we think about all those things is that what's been really neat for me in doing some work kind of on the evaluation side with Kathy's team, but then also just learning more about food as medicine initiatives and how food insecurity affects our clinical care patients, is to meet a bunch of other folks in town who are really interested in this space as well and working on a lot of those different angles. So you mentioned food deserts or access to healthy. There are some really great teams, Emory and around us, that are thinking about that in particular, creating really cool networks where it's not just about, can we bring healthy foods into the healthcare sector, which is really what food as medicine is thinking about. But even upstream of that, can we partner with farmers to figure out how, we can get some of that healthy food that's grown right here into the hands of folks that really could benefit from it. Thinking about mapping, neighborhood mapping, and how mapping can affect like how we distribute resources if we know that they're available. So I will say, my perspective is yes, it feels like a lot of that is contributing to these issues we see around food insecurity. But I guess the hopeful part of that also is that it's been really great to learn from this network of folks that are really interested in it from all angles. Kathy, I'll pass it to you because I think you know a lot more about it.
Well, I won't say I know more than you do, but I've been, interviewing patients for 29 years, and I've been here at Grady those 29 years, and I see, in our interactions that what they eat on a regular basis, and fruits and vegetables were not a part of that diet. It was rare. They would have greens on the weekends, but that was the only time they were really getting fruits and vegetables in. And, it is a food desert. There's no grocery stores nearby for them to regularly get those kinds of foods, or farmers markets for that matter. So to bring this to them as a program, there's a little resistance in the beginning because they're not quite sure what they're in for. But the important part is that we have a fantastic team that works with these patients and they're really kind and generous in introducing patients to this concept of, you know, changing their food ways, changing the landscape of their plate to better manage their diseases, and we've partnered with Morehouse and Emory physicians for them to come in and actually sit down with the patients to go over what we call report cards, where they discuss their lab values. And they become so much more knowledgeable in terms of their health and how their food really affects their labs and even how they feel. When we surveyed them, they showed that, from beginning to end, there were fewer days of feeling poor throughout the month. Even mental health had improved for our patients. So it goes so much further than, you know, just what we may see on the surface for our patients.
That's amazing. I love that you're also using the interpretation of lab tests to show, hey, you're making great progress here, and the biochemical, but also physical feeling level. I want to talk a little bit about the economic burden of some of these diseases when they're left unchecked. And we've not met in person, but I'll tell you, I'm an amputee. I have a prosthetic leg due to a childhood series of congenital defects. And today, whenever I go to my prosthetist office, I would say that 99.9% of other patients are diabetics that have lost limbs due to poor circulation, infections, and things that kind of cascade down. So, can you tell us a bit about the public health burden, Rosette, of unchecked or poorly controlled diabetes? What does that mean for a patient? And what does that mean in terms of healthcare costs? I know we're not talking about economy here, but I just kind of want to get a perspective because you could have some that would say, well, why should we invest in food? You're a hospital. You know, Tell us about this actually is an incredible investment, because we're helping to stop some of those greater expenses down the road.
Yes, absolutely. So I think, I work in the space of both diabetes prevention and management. That's the fun of being a primary care doctor, is that you get to kind of work on all of it. And so I think for me, thing that I notice is that every step of this, preventing diabetes, managing diabetes, it kind of is like, you can see that when things are controlled, everything stays nice and steady. When things get out of control, it kind of like tumbles and it's hard to catch up to it once it starts getting out of control. And so I think that's where things like this are a huge assist in terms of helping folks keep an eye on things like labs, like what Kathy was saying when they're visiting with us or chatting with a nutritionist. If things are starting to get out of control, which happens because life happens, these are ways that people can kind of get back, reframe, get back to the basics on things like nutrition or physical activity. But just to kind of broadly talk about how this is, when someone comes in with diabetes, the things that we really want to work on are preventing the long-term complications of disease. Because as you mentioned, those are the things that are not just high cost, but those are the things that are the morbidity and mortality associated. So we want to prevent folks from retinopathy, which, in basic terms, it's that we want to stop you from going blind as a result of this disease, right? We want to prevent nephropathy, which would be kidney disease, which can certainly happen from uncontrolled diabetes. We want to prevent neuropathy, which is the thing that leads to what you were mentioning, amputation. So we have a lot of folks who, have high blood sugar numbers for a really long time. They're not able to get it under control. Maybe at some point they are able to, but because they had a very long period of time where they were uncontrolled, it increases their risk of all these things happening down. What we know is that the sooner we can get these numbers under control, the longer we can keep them under control, the less likely you are to develop any of those complications down the line, even if you're living with the disease for a very long time. And so a lot of this upstream work, you're exactly right. This is the part that we're trying hard to show folks, is that if we can get these things well managed up front, then the prevention part of that is really going to be seen down the line, many years maybe down the line, where we don't see those amputations. We don't see the need for dialysis. We don't see the blindness that can still happen. And I think when we think about those things, for some people, it really shocks them to realize that diabetes can do all of this, but it really can. None of that even mentions the cardiovascular mortality kind of issues that go with this, morbidity and mortality. So heart attacks, strokes, all of that is something that can happen as a result of diabetes. And the better control we get over it definitely decreases those risks down the line. I think a lot of times we talk about that a lot when we're talking about the medications folks can use to treat diabetes. But in this sense, I think this is exactly where we want to bring in the conversation of, if we can get folks on a healthy diet, good physical activity, that's just as powerful in many ways in terms of keeping the complications out.
Amazing. I mean, it's such a simple and obvious solution, but yet socially so difficult to implement because of all of these different socioeconomic barriers to access to food and food knowledge. Um, I know that in our audience, we have a number of listeners also coming from other hospital systems across the country and even globally. I'd love to learn more about how this program got started and if you all have any advice for other centers that might be interested in trying to launch something like this.
I to I've had that question to us lots of times, and people want to know, what can we do to convince our hospital to, buy into this kind of program for our patient? And it really is for us, it was looking at the data for the number of patients with uncontrolled diabetes, uncontrolled hypertension. That's the two disease states we are working on as a program. And it was also looking at the data for our food insecurity levels. And what we did is combine that so that as a patient comes into to see their primary care physician, they are screened for food insecurity with our social determinants of health screening. And so if they are found to be food insecure and they have an A1C above 9 or a blood pressure above 140/90, a stage 2 blood pressure, then they are eligible for our program. And so we've set it up in our electronic medical record that a best practice advisory will fire for those medical assistants who are doing the screens. And that will allow them to send a referral to our food medicine program as well as to the dietitian so that appointments are set for those patients. And so to maintain their, once they come down to the clinic and get enrolled, it only takes about 10 minutes to get enrolled. Once they do that, there are requirements to stay in the program. So every 3 months, the patient needs to um, pick up their produce every 2 weeks. They need to see their dietitian once a month. And then they also need to go to a cooking class at least once during that 3 month period and then circle back to their physician. And if they do that, they can continue in the program for up to a year. And so that's how we've set it up and how the patients understand it and it works for them. So I would say to anyone trying to get this started, get the data together to show your leadership that this is an issue that can be handled and managed through, you know, like you say, uh, kind of simpler means, simpler ideas of nutrition and exercise and education, which sometimes it doesn't go across so well. It's not big, it's fancy, but it is. We've had great results. We've seen in our population, on average for our uncontrolled diabetics, a 2.4% decrease in their A1Cs, and that's uh, 30 milligrams per deciliter for every 1% decrease in their blood sugar. So that's huge. Just like Dr. Chakkalakal was saying, we are saving amputations, we are saving vision, we are saving kidney function. Really saving lives by doing this change. And many of our patients, they come in with a 14, 15, 16 A1C. And when they leave after the year, they're down to 5s and 6s. So it's really putting many of our patients in remission, which has not been a word that we've ever used for our diabetics, to say, hey, you have this opportunity to put yourself in remission and it's almost like you don't have the disease anymore. So this has been pretty miraculous for many of our patients to be in the program.
Incredible. There's a topic under debate that's going to continue, I'm sure, to be under debate, and that's the status of GLP-1s for Medicare and Medicaid coverage. And one could do just a purely economic analysis of the cost of pharmaceuticals to treat diabetes. We have, of course, many other diabetes pharmaceuticals besides these GLP-1s. But then there's also the question of, what is the cost of implementing a food pharmacy, a teaching kitchen, these types of programs? Have you all done any kind of economic analysis of this, or is that something that's kind of part of your ongoing research to really understand, you know, how this might work on a larger scale? Because I think there's a lot of great data when it comes to the clinical outcomes. Can we think about, is this scalable at a national level?
Yeah. So I think um, a good starting point there is to say that evaluation is very much in process. So Kathy and her team are always evaluating their data. So one thing I just wanted to highlight from kind of point that you both have made before, and I think it's really important for others to recognize this, when Kathy and Dr. Bussy Jones, Dr. Schmidt, the leadership of the Food with Medicine program, Leslie Marshford, others set it up, they did this thing that really, I think, makes a huge difference, which is that they really recognize it as a key part of clinical management of our patients dealing with chronic disease. And so all documentation of what happens when the patient goes to the food pharmacy shows up in the same medical record system that I use to take care of my patients in primary care clinic, that the specialists use over at diabetes clinic, cardiology, everything. So they are just as much a clinical entity as any of our other clinics. And by that same token, I can look and see what's going on over in the Food with Medicine program for the patient that comes and visits me a little later on, and we're looking at A1Cs. So I think the connection there is really important because it highlights that the importance of recognizing food as medicine as very much a part of disease management, but also it facilitates a lot of communication in ways that doesn't always happen when you have kind of, maybe a food as medicine program that's separate from the healthcare system and you have to kind of rely on a lot of other like porous ways of kind of getting the information across. So when, when Kathy mentioned that we do social determinants of health screening, for example, in the clinic, we do that in our clinical visits. We're checking with folks if they're food insecure. If they are, and we see that they have an uncontrolled chronic condition, it is so easy for me to click on the referral button and get them in to see Kathy. And if for some reason the referral button's not working right for me, I send a message to Kathy and I say, hey, it's me again, help me out. And she's helped me a million times. So it works because we're all very integrated there. It also helps on the evaluation front, which is what you're talking about, economic and evaluation and otherwise. There's a lot of interest in studying it. I think what we want to make sure is we're asking it the right way. So, it would be great if we could say, oh, we did an intervention, we plopped it in, here's all the costs needed. I think what the Food as Medicine program really captures is that these are complex conditions that require complex management and hopefully will lead to good, solid outcomes. What Kathy was mentioning that there are a lot of patients that are in the program who really do well. Again, a lot of that is because part of the requirement is that they have to stay engaged with their provider during that time too, right? So we're not saying, oh, this is a program that replaces all of that. We're saying yes, and, right?
Mhm.
So medical management, continue with the medications that we know are really good for you and that can improve your outcomes. Add in this lifestyle component that we haven't been able to really support many times historically in healthcare systems before. And I think the patients with feeling that support and seeing success, it keeps them coming back and kind of doing these interventions with us in a really different way. It's a different level of sustainability, I think, for the patient. And the Food as Medicine program has very strong partnerships with all of the clinics. So they don't just say, hey, refer to us if you can. I mean, they have people in the primary care center like me and other attendings that have been there for a while trying to like really remind everybody to do the screenings and then referrals. We work with a lot of resident physicians, so this is an excellent way for us to be able to teach residents about the importance of social determinants of health, as well as like how do you actually practically handle those when you're in a visit with a patient. But then, Kathy, I think the diabetes clinic is a clinic that works with you guys very closely. They have their own lifestyle change programs, but then also will partner with Food as Medicine in many ways. In cardiology does a lot of referrals. We all get this email from Kathy that kind of says, hey, look at how many referrals I got from you this month. Keep going. So she keeps us really informed of what's going on. So there's a huge buy-in from the providers too. So I think to answer your question, more to come on the evaluation side as we kind of come up with the right ways to see how it works in with our existing program.
That's amazing. I'm also curious. So they're enrolled for a year. I'm assuming they're going to continue meeting with their medical care team. Are there kind of check-ins to see, are they keeping up with some of the strategies learned, or are they able to access fresh produce after this year? Or I don't know if it's still probably early days to understand this, but maybe Kathy, you've got some insights there. Like how sustainable is this post-program?
Yeah, and that's where our partnership with the Atlanta Community Food Bank really has been very important to us. We meet with them every other week. We talk about the foods that are coming in, the quantity, the quality, the variety, because all of that matters. What a patient what they eat really matters. And so, and they do get really upset at graduation when they're like, is this going to end? And we assure them that it's not. And we developed and put into implementation last year, 2024, what we call the neighbor program. And this is where they are able to continue to give fresh produce and dry goods for their family for another year while we try to. We're in the process of trying to even connect with farmers and community gardens so that patients can have, more access and a more understanding of where their food comes from, and even a place for physical activity to connect to make those connections with that community. But yeah, we now have that in place and have been working with that neighbor program for the last 6 months, and so uh, as well as not only are our graduates being able to go into that, but we've now opened that up for transitions of care patients who come in food insecure who do not have uncontrolled disease states. So we're really trying to expand what we're trying to do for more patients here at the hospital.
And I'll
Amazing.
also say, just to plug what they're doing there, because they do a whole lot in the food pharmacy and the food investment program, but a lot of that is because they also listen to us. So we were kind of mentioning to them, our patients, we were hearing them sat when they were kind of done with the program. And I think it highlights this really important point, which is that, food insecurity is something that may persist for the person beyond that year, right? It may come and go at various times in a person's life. Same thing with disease management. Sometimes it can be really good, but maybe sometimes like things that are happening in life are kind of driving things out of control. And so when we talked to Kathy and her team and kind of mentioned this is something that we hear, that's when they started developing things to make sure people feel supported, even if they're not officially in the program. The other thing that they do that I've seen you guys do plenty, Kathy, is help folks understand if they're eligible for other programs, maybe other benefit that could really help kind of fill in these gaps. Because I think we all know just navigating that process is very complicated. And so having folks that work with this all the time and can help people really understand that, also find some other resources that can be really helpful.
We have a benefit screener that comes into the clinic once a week, and we have put that benefit screener in some of our outpatient clinics as well, which sure, just exactly what you're saying, that they are aware of other benefits that they can partake.
Well, Atlanta is such a great community, I feel like, in the food scene. We have the Edible Food Forest, we have the Community Food Bank, we have organizations like Concrete Jungle that forage, wild foods available in the city. There's a lot of, I think, of interesting activity, and it's great to learn more about what you all are doing at the hospital. I want to turn a bit more now to the education component and learn a little bit more about your teaching kitchen, the where you're really learning these skills. And what is the average, or is there kind of an age range for people? I know this is for adults. Like, are these older adults, younger adults, a mix of all of that? And what are the cooking skills that you're really focusing on in these classes?
Yeah, well, and we welcome everybody into our class, whether it be that patient or them and their caretaker or them and their spouse, whoever's doing the cooking in the household, we invite them in. And we have an age range from like 19 to 90 years old. So I know it's everybody and anybody. We have multiple cultures. So we bring in our language interpretive services to make sure everybody is able to understand and comprehend. But it's more than just cooking skills. It's more than just let me show you how to cook what's coming out of the food pharmacy this week. But it's also a connection point for the people in the community so that I don't know if you remember way back when you maybe went through organic chemistry lab and how scary that was on the first day. This is kind of like that for our patients. They come in very nervous. And so our teaching kitchen manager, Donna Blissett, puts them at ease and just makes them feel very comfortable, like like they're at home. And so they can talk to each other and be really comfortable. And so they're making that kind of connection, as well as, like I said, we also bring in our physicians from Morehouse and Emory and set up that relationship. It's a different kind of relationship when you sit down one on one with your patient and really walk them through their lab values or what they're doing, lifestyle wise that they maybe could improve on. And so the patients get a different view of their physician, and the physician gets a different view of their patient because of that relationship. Um, so again, they have to attend at least one of those cooking classes every 3 months. They always want more after that first one. And like I said, we're serving the whole family. And what they take from that class, they tend to go back and tell neighbors, their church folks. So it becomes a real neighborhood education point.
That's great. Man, I would love to see this in schools. It makes me so sad to see teenagers that don't know how to cook because that's really where they set a lot of their habits. And maybe that can be a dream for the future. But it's fantastic what you're doing right now in
Absolutely.
patients and bringing that value. I mean, out of the years that you've been doing this, Kathy and Rosette, can you share with us some examples of success stories? Like, what are some of the feedback points you get from some of these patients?
Kathy, I'll have you share first.
Okay, I have one that's just kind of reinforces what we do. We're a fully plant-based program. So, like I said, we're really trying to change what the plate of that patient looks like. And we've had a couple of patients who were on dialysis. And as dietitians, we're never told that patients are ever going to come off of dialysis. Once they're on dialysis, that's going to be their lifestyle. We've actually had several who've come in, changed their diet the way we were talking to them about, the way we've educated them, and their dialysis days have gone from 3 days a week to 1 day a week. So to see that improvement and to see that quality of their lifestyle change because of that, I mean, that is miraculous. And the patients are just so grateful. When they go through graduation, they give shout outs to their physicians as to being the people who got them into the program. And so, again, it just makes for a different vision of our patients for their care and for the hospital and how we treat our community.
Yeah, I'll echo what Kathy just said there about, the patients really set the tone of this program. And I think they really are the ones that have shown us how great it is, not just for them, but for us. So, I think Kathy's mentioned a few times that they invite providers down to the food pharmacy or to the cooking kitchen or to the teaching kitchen for the cooking classes. And so a lot of our learners and a lot of us may want to just go down there and hang out because, we don't get a lot of nutrition education when we're learning how to become doctors. And so this is actually a great way for us to get some help in understanding what are some feasible things that we can teach our patients during clinic visits that maybe Kathy's team can then, go into more detail when they show up for their education class. So it's a huge learning opportunity for us, I would say. I will also say it's something that I've noticed it is as an evaluation kind of person that looks at all the questionnaires that they do with patients and all these other things. It's so sensitive to the needs of the patient. So one of the questions that I remember seeing in one of the questionnaires that they developed, and they continue to use it, is just to ask folks what kind of kitchen supplies do they have at home? Do they have a stove? Do they use a microwave? Do they have a refrigerator? These are things that we kind of take for granted maybe that everyone may have access to some of these things. But they really just start there and they normalize it and they make sure folks know you can talk to us about this. Do you have your own stuff? Is it a group home? Is it something where you may not have access to it all the time? And I think that's been so helpful to the patients in feeling like, yeah, I can talk to these folks about this and tell them where I'm at and see what I can do with what I have. Which is important, not just for food, but maybe even some of the medications they use, understanding if they have a refrigerator. For me, I'll just say, I feel like, so I trained at Emory and Grady through Emory as a resident, and I was gone away for some time and came back. And so the food as medicine program was flourishing by the time I came back, which is why anytime I get to chat about it, I always want to have folks like Kathy and all talking about it as well, because they saw it grow up and really developed it and made it into this amazing program that, many of us now get to work with. But a lot of what I learned about it was by my patients telling me how much they liked the program. So I used to see folks, for example, bringing in carry-on suitcases to the clinic sometime. And I told Kathy one time, I was like, I didn't realize that was something that was part of the program, but it's because, a lot of our folks may have transportation insecurity. They don't have their own car. So to carry all the great produce and food that they're getting from the food pharmacy, they need to take the bus. And so they may need something with wheels to just help them transport it. While we're working on other ways, are there other ways to do this so that they don't have to come in? We don't know. But in the meantime, this was a great solution. And the patient was like, this is great. They gave me the suitcase and I can do it. So, something like that. I think the other thing that I've learned from them oftentimes, like they may get something there that they don't know how to prepare. They're very excited to learn how to do it. Or if they don't, or if they don't like it, they're like, I just shared it with my neighbors or my family members, because that is this community. They take care of each other. They take care of us. It's a very, they want, everybody's trying to help each other. And I think, I mentioned that one time when we were on a call to Kathy and other leadership, and they're like, that's exactly what we want. We want the reach of the program to be beyond the one-on-one with one patient, and it definitely.
Awesome. Well, where do you see the program going? We're at the beginning of 2025. Do you have any plans for expansion of the program, or what are the big foci for this year?
Um, we for expansion, there are other components. So I mentioned the neighbor program. We will be expanding that into other clinics. We will be our first clinic that we're going to be working into this next year is oncology, which you know doesn't necessarily have the uncontrolled chronic disease that we have in our foodist medicine program. So allowing them to come into our neighbor program really starts to provide those people with a service that's really necessary, especially in oncology and cancer treatment. Um, Another component of our program is what we call the fresh food carts, which we have a mobile food distribution for produce to our patients at 3 other clinics in the city. So we are at Asa Yancey, Ponce, our Ponce clinic on Ponce de Leon Avenue, and Brookhaven. Today is our Brookhaven distribution. And so we hope to start having more of those south of the city because we know that the community that really needs attention. And our health equity officer, Dr. Wimberly, has really brought that to our attention. And those are our patients, so we want to start serving them at a better rate.
Amazing.
I was also going to just mention that a lot of what we're also working on from the program itself is just optimizing program delivery. So, we that has been something that I think what Kathy and others have taught me is that these programs take time to figure out like how they work, how we can get them to continue working. And so, as I mentioned, she always gives us feedback on how many referrals, for example, we're placing and how many of our patients follow through on that. Sometimes we're going backwards in our clinics and looking at, hey, why did we miss that referral, or why didn't that one come through, and kind of optimizing the way that we can get that first step to happen. And then something that Kathy and myself and others have been looking at is, so they get that first prescription of 3 months. We don't see everybody refilling it. And oftentimes that's because they're encountering a barrier to maybe refilling. Not because they don't like the service. They really like the service, but maybe there's a barrier to following through on kind of some of those program requirements. And so we've been thinking a lot about how we can kind of help out with that retention piece, and seeing, what's feasible for the patients, but still effective in terms of giving out, the interventions that we need. So continuing to work with our patients to see how we can make it better. And then you actually mentioned some of the stuff that we were also thinking about is like with new medicines like GLP-1s and things like that. Nutritional needs are different for folks now when they may or may not be taking medications. And so sometimes we're thinking about that, like, different users of different medicines, different populations, just like Kathy mentioned, and where could we kind of plug the services in and how do we adapt them for our patient?
Great. Well, we know that Grady is a social safety net serving hospital. Where does the funding come from to support this program? Are you all grant funded? Are you based on philanthropic funding? Are there ways that listeners might feel, moved to help support this exciting program? Are there ways that they can do that?
Yes. Currently, we are fully donor funded and grant funded. And if you are interested in donating, we would steer you to our Grady Foundation, who have been tremendous partners in this in regards to ensuring that we continue to remain funded. Um, we also, if you are interested in working with us, we have our events on Hands on Atlanta site to volunteer, and we are truly grateful to the volunteers. I mentioned our fresh food carts. We've had over 3,000 volunteers work with us at those fresh food carts. We could not do this without our volunteers. So if anyone is interested, we take businesses, we do team building with them. So go to our Hands on Atlanta site, handsonatlanta.org, and sign up.
That's great. I love that because, not everyone listening may have additional funds to donate, but we can all give a bit of our time to help out our community. I think that's such a great message. Fantastic. And is there a website for the program at Grady where folks can learn to the Hands on Atlanta is a volunteer site? Is there also information for patients that might be interested in this program?
There are the gradyhealth.org, and you can look up foodist medicine from gradyhealth.org.
Fantastic. Great. Well, I
And
want
I'll
to
say that the location of Jesse Hill Market, which is kind of the market right there on the corner that Kathy mentioned, it's very easy to find. So I think a lot of times folks feel like when they get to a medical center, there's like places all over the place. It's really right. Kathy, is it fair to say like pretty much across the street from the MARTA station? Like if you just kind of cross over and walk
A
over.
block away. Absolutely.
Fantastic. Well, thank you both so much for sharing all this incredible information about this program. I'm really excited about this. I think that there are a lot of, you know, pearls that we can learn from programs like this and how to help improve health across our communities in the country. And what you're doing is so incredibly important. I'm sure you already know that, but I just have to say it so important and impacting so many lives. So thank you for what you do. And thank you for coming on the show. That's it for today. I want to thank our listeners for tuning in each and every week. And thanks to our producers, to Rob Cohen and Christine Roth, for putting on a great show. If you want to find the video version of this episode, you can head over to our YouTube channel at Teach Ethnobotany in the Foodie Pharmacology playlist, or you can listen to the audio version of this and all of our other episodes at foodiepharmacology.com. Of course, we're on all the major podcast streaming services. You can head over there. If you enjoy this show, I could really use some help in getting the word out. Share it on your social media networks, let your friends know, give us a 5-star review on Apple Podcasts. All those things can really help us along. Thanks so much for listening. Stay healthy out there, and I'll see you next time.